Hello, and welcome to the University of Washington, Washington Area Cardiometabolic Project ECHO Session 7. I am Dr. Laura Montour, and I am a family physician and obesity medicine specialist here at the University of Washington. I am very excited today to introduce Session 7, which will be on insulin titration and use of insulin with insulin-sparing agents. Our talk today will be presented by Dr. Gail Nunlee-Bland, who is an endocrinologist at Howard University. Our panelists today include Silu Zhu, who is a clinical pharmacist at Harborview Medical Center. We also have Dr. Savitha Subramanian, who is an endocrinologist and lipid expert at the Diabetes Institute here at the University of Washington. We also have Allison Evert, who is a dietitian and certified diabetes educator and manager here at the University of Washington. So with all these introductions out of the way, let's get started.
Hi, I'm Dr. Gail Nunlee-Bland, and I'm going to talk to you about insulin titrations and how do we use insulin when we have used many of the other agents that we've been using for treating diabetes. I have no disclosures. The objectives of this talk is, one, is to define the classes of insulin and the pharmacodynamics. How do we titrate insulin to achieve glycemic goals? How do we use the insulin with insulin-sparing agents? Using diabetes technology to enhance diabetes control. We have to be well aware of their insurance formularies for prescribing diabetes medications and their patient assistance programs, because we all are aware that insulin is very expensive and many of our patients need help. I'd like to first start off with the history. And Charles Best and Frederick Banting in 1921 demonstrated that pancreatic extract, when administered to a dog with diabetes, resulted in a decrease in urination. And so this was then used in people, young boy by the name of Leonard Thompson, who came to the University of Toronto where Best and Banting were, and they injected him with this pancreatic extract. And it was a remarkable change in terms of his clinical picture, where he began to gain weight and stop urinating. And in the 1930s as well, Eli Lilly began to mass produce insulin, which was extracted from basically animal source. It wasn't until 1978 when investigators from Genentech was able to clone and show expression of the human insulin. And this has opened up all of the insulins that we're pretty much using now in terms of human insulin. So I want to talk to you about the insulin classes. And these classes include the rapid, short, intermediate, concentrated, long-acting, premixed, and premixed with GLP-1 agonists. And it's important to know these classes of insulin and how to use them. So starting with rapid-acting insulin, we have several on the market, and Lispro and glulisine and Aspart are rapid-acting insulins. But now we have some of the, what we would consider almost designer insulin, where they've made these insulins faster acting. The Lispro AABC has a peak of in 2 hours, which is to be mimicked more in terms of what the pancreas would normally peak. And the Lispro follow-on products are the ones that are supposed to be cheaper in terms of insulin agents. And then in terms of the onset of actions, the peaks, the duration, and the appearance, these are these insulins. And I always like to educate my patients regarding this, particularly the types of insulin, because sometimes mistakes are made from the pharmacy, whether they're getting mixed insulin with NPH or some of the other ones, protamines, that those may be cloudy and sometimes mistakes do happen. So it's important that they know their insulins that would be clear, or if they're contaminated, if they become cloudy. But these rapid-acting insulins generally will have onset within 15 minutes, peaks in about an hour, and has a duration of anywhere from 3 to 5 hours. The one that is a little bit different, which is the different one, the Lispro AABC, has an onset pretty much close to the rapid-acting insulin, but it peaks a little bit later in 1 to 2 hours and has a longer duration of action. We also have the Technosphere insulins, and this is the inhaled insulin, and it is a very rapid acting insulin. Starts to work within 5 minutes, peaks in 15, and the duration is 3 hours. And it is a powder form where the patient inhales the insulin. Now, with this one, you want to make sure that there isn't any evidence of COPD or they're smokers, because it can be an effect in terms of their lungs, particularly their FEV1. And we generally like to get a baseline FEV1, repeated in 6 months, and then every year. And if there is a 20% reduction in the FEV1, then you would stop using this particular insulin. We have short-acting regular insulins, which has a slightly longer onset of action of 1 hour, peaks in 2 to 4, and has a duration of 5 to 8 hours. And it is also clear in appearance. And then our intermediate-acting NPH insulins, those have been around for a long time. The onset is 1 to 2 hours, peaks in 10, and duration of 14 hours, but this is cloudy. And the intermediate acting NPH insulin may have more hypoglycemia when you use these particular types of insulin. The long-acting insulin, which includes the detamere, glargine, and de-escalate, and they just have put on the market the biosimilar insulin, the insulin glargine YFGN, which is similar and is interchangeable with the glargine insulin, supposed to be a little bit cheaper in terms of cost. And I know many of the Medicaid formularies and some of the other commercial insurances are moving towards this insulin glargine YFGN. And so when you look at the onset of actions of our long-acting insulins, generally the detamere onset is 3 to 4 hours. It has a relatively flat peak and may last up to 20 to 24 hours. It is again clear. Glargine and the glargine YFGN have the similar profile and may last up to 24. And the de-escalate has a slightly longer duration of action. Onset is a little quicker and has somewhat of a peak in about 9 hours. We have our insulin mixtures, which is the NPH regular, with 70% of it is NPH, 30% is regular. We have our protamine, Lispro, 50-50, protamine, Lispro 75-25, and our protamine aspart 70-30s. And we tend to use these particular insulins, particularly when individuals may have difficulty giving multiple injections a day. These insulins tend to be a little bit cheaper in cost. This is when we use these insulin mixtures. And looking at their onset of action, again, 15 to 30 minutes is generally when these insulins begin to work, peak in anywhere from 0.5 to 3 hours, duration up to 24 hours, and these are cloudy. Sometimes what I have found in with some of these mixed insulins, because their names are very similar in terms of when they go to the pharmacist, sometimes they're accidentally picked up and the patient's thinking that it may be the rapid acting insulins, and they end up injecting as if it was rapid acting insulin. So I always like to make sure that the patients are aware of what the appearance of their insulin should be. And we have concentrated insulin, the U500 regular insulin. And this one is typically used when patients are on large doses of insulin, usually more than 200 units a day. And the volume of injection will be much smaller, and the absorption of the insulin is better with this concentrated insulin. And most of these concentrated insulins are useful for patients who need large doses of insulin, generally more than 40 units a day of these. And they sometimes have longer durations of action and improved profiles when using concentrated insulins. And we have the pre-mixed insulins with the GLP-1 receptor agonists. And the two on the market are the glargine lixisenatide and the de-escalate liraglutide. And this sometimes can be used for someone who is already on a GLP-1 and you just want to add a basal insulin with it. This would be a one shot to be given rather than multiple shots given, and it can be given on a daily basis. So when do we use insulin? Definitely for type 1 diabetes, For gestational diabetes, not meeting glycemic goals. Type 2 diabetes, when they're symptomatic, particularly at the onset of diagnosis, blood glucose are greater than 300 milligram percent, or if they're not reaching glycemic goals despite maximally tolerated oral agents or non-insulin injectables. When you find that patients who are not meeting their glycemic goals after trying multiple agents, it's probably a good idea to check to see if this is immune-mediated diabetes and getting diabetes antibodies, including islet cell, glutamic acid, decarboxylase insulin, tyrosine phosphate, islet angiotensin 2, and zinc transporter. What I have been finding is that I often can't look at an individual to determine whether they're type 2 or type 1 because some of the type 1s are obese as well. And for those that are not responding to the typical treatment paradigm, they may have autoimmune diabetes. And then, of course, glucocorticoids, certain medications, severe stress from illness, the oral agents or the non-insulin injectables may not work as well. Then many type 2 diabetes patients have progressive beta cell loss. They've been doing well for years, and then all of a sudden you have to add more and more agents and then no longer working, and you have to add insulin. So when we're treating our patients, and we try to treat them to goal, but you also need to be aware that the glycemic targets need to be individualized, and that individuals who may have hypoglycemic unawareness, individuals where their social situations will not allow them to do multiple injections a day or multiple therapies, those who have chronic illnesses with multiple vascular complications or reduced life expectancy, the strict glycemic target of an A1C of less than 7% may not be optimal. So you have to take the individual patient and assess their risk factors to determine what will be your target goal. How do we define insulopenia? Because we thought many years ago that there was type 1 and type 2 diabetes, but we realized that there is a blending of these diabetes, and that so there can be type 1 diabetes that have positive autoantibodies, but they have residual beta cell function and can produce insulin. We can have type 2 diabetes where autoantibodies are negative, but they have no beta cell reserve. Our usual type 2 diabetes where there's insulin resistance and they're not insulopenic, that is one. And then you can have your typical type 1s where they have autoantibodies and are insulopenic. So definitely for the type 2 diabetes, CMS has guidelines in terms of the definition, and it defines it as a fasting C-peptide that is less than or equal to 110% of the lowest limit for the lab, with a simultaneous blood glucose of less than 225. And sometimes that is a challenge, particularly for the type 2s that we may want to put on an insulin pump. We have to demonstrate this. Also, you can do glucagon-stimulated C-peptides, and after giving the glucagon, if the C-peptide is less than 0.2 nanomoles per liter, but that's really not practical in a clinical setting. So, initiating insulin. There's patient barriers and then there's provider barriers. Many patients complain that I don't want to do an injection, I fear hypoglycemia, or I remember my relative, when they started insulin, they went immediate to dialysis. We hear that a lot. And this is something that we have to overcome when we talk to our patients about it, particularly with the needles that we have that are very fine, they're small, you barely feel the injection, so there's little or no pain. Then there are the provider barriers. Again, providers, it takes a lot of time to educate someone on how to inject insulin. And if you don't have the support staff in your office, that makes it a little bit difficult to initiate insulin therapy. Again, you have your patient resistance who don't want to do it. And then there's the lack of confidence if the patient's ability to manage insulin therapy or hypoglycemia when they do initiate insulin. So when your patient needs to start insulin, how do we do this? And usually we start with basal insulin titration. And I'm sure that you probably have seen this busy slide in terms of what is the goal of treatment. Generally, the first line is metformin, and then what are the comorbidities associated? If they have heart failure, atherosclerotic cardiovascular disease, or diabetic kidney disease, you may be adding a SGLT2 or a GLP-1 as your second line agent. Or if they don't have these, but weight is a concern, then maybe a GLP-1 is your next line of therapy. And then also we have to consider costs because these treatments are very expensive. But with you're using these various medications and you're not reaching goal or your target goal in terms of your glucose and your A1C, then insulin may be necessary. So when you add insulin, of course, and you want to reinforce your diet and your exercise, but consider adding that GLP-1 before you add insulin if it's not contraindicated. And after that, then consider your insulin treatment if you're going with injectables. I usually like to use weight-based therapy, and starting at 0.1 to 0.2 units per kilogram of body weight is the dose that I generally start with. I know there are those who start with 10 units, but it takes a longer time to titrate up, and I'll talk about the titration algorithms. Or you can use bedtime NPH as a starting for basal insulin therapy. This is a busy slide, and I will walk you through the next steps in terms of after starting insulin, and usually basal, whether you use long-acting insulin or NPH, how do you titrate this patient up? So there are several titration algorithms, and I'll present these to you. One is starting with a basal insulin of 0.1 units per kilo per day, or 0.2 units per kilo per day, or 10 units, whichever one you feel comfortable with. Every 3 days, depending on what their morning blood glucose, you would increase it by so many units. So if their blood sugar happened to be 200 over the past 3 days, then you would increase that basal insulin up by 6 units. If it's less than 80, then you need to decrease that basal insulin by 2 to 4 units. And once you reach 0.5 units per kilo per day of basal insulin, then you're going to have to think about adding prandial insulin to your therapy, because many times we over basalization of our patients, and then it's just too much basal, and then we really can't correct them. And we really need to look at prandial coverage of insulin. Here are some other titration algorithms that were in clinical trials using glargine. And again, they looked at the fasting plasma glucose. And if your blood sugar is between 100 to 120, using 100 as your target, then you would increase it by 2 units, and you would go up to 8 units if it's greater than equal to 180. And then the predictive study, where they increased it by 3 units every 3 days if the fasting plasma glucose was 110 milligrams per deciliter. So these are those forced titration algorithms that are out there. This one is for basal insulin after you have looked at your fasting plasma glucose, but you begin to find that your prandial blood glucoses are somewhat elevated. You can use this algorithm for correction, either using rapid-acting insulin or short-acting insulin based on the blood glucose target. So you can see here based on this. And what I generally will do is I will give my patients these algorithm targets for those that I think that are willing to do this, so that you're not waiting for that patient to come back in 3 months with no changes in terms of their insulin titration, and you have not reached goals. So this is very useful to getting your patients to self-titrate and try to get to goal as quickly as possible. Once you have titrated that basal insulin and you have reached that 0.5 units per kilo per day of basal insulin, then it's time to look at your prandial insulin titration. With the prandial insulin titration, we tend to add the prandial insulin with the largest meal of the day. So you can either use zero point 0.1 unit per kilo as a starting dose for your prandial insulin, or start with 4 units or 10% of the basal dose if your A1C is less than 8%. And again, just increasing by 1 to 2 units every 3 days, or at least twice weekly, until you can reach your blood glucose target. If the patient becomes hypoglycemic, then reduce your insulin dose by 2 to 4 units at the time. So again, looking at the time of the day that you see the hyperglycemia is the time of day that you need to make corrections in terms of your glucose. So if you're finding using your largest meal of the day and it happens to be dinner time, you're looking at your bedtime glucose to see if your blood sugar is within target range. And once it reaches that, then you can look at the other times of the day that maybe you're not reaching target and begin to add additional prandial coverage. So for your lunchtime elevations in blood glucose, you would titrate or add rapid acting insulin or short acting insulin to your breakfast dose. If your dinner dose blood sugars are elevated, then you would increase your prandial coverage or add coverage to your lunchtime. And then, of course, if you use dinner, then it would be your bedtime. So looking at those times of days and looking at your blood glucose levels will indicate when and how much you will increase your prandial or add prandial insulin coverage. This is a busy slide again, and this one is pretty much similar. And there are a lot of them that are out here. And it also depends on whether their A1Cs are less than 8%, using 0.1 to 0.2 units per kilo per day, or if their A1Cs are greater than 8%, then maybe using 0.2 to 0.3 units per kg per day. And then adding basal plus 1, the largest meal of the day, and then keep titrating in basal 2 and 3 until you can reach target. So the prandial insulin titration, the American Diabetes Association provides in terms of guidance of using the 4 units or 0.1 unit per kilo or 10% of your basal dose if A1C is less than 8%. The American Association of Clinical Endocrinologists, they began with the prandial insulin dose before the larger meal of 10% basal or 5 units, so a little bit more aggressive. And then if not at goal, progress to injections before 2 to 3 meals. Their target blood glucose is a little more stringent. If it's less than 70, you reduce it by 10 to 20%. And then if the blood glucose is less than 40, you reduce that dose by 20 to 40%. When an individual is on 3 injections of prandial insulin plus basal, then we're into the basal bolus treatment regimen. And usually 50% of your total daily dose will be basal, and then the other 50% will be prandial. And most individuals will need somewhere in terms of a total daily dose of 0.3 to 0.5 units per kilo per day. You would titrate again every 2 to 3 days until you can reach your target by either increasing by 10% or 1 to 2 units if the 2-hour postprandial or next pre-meal glucose is consistently greater than 140. And then if it's less than 70 or less than 40, you reduce your prandial doses accordingly. For those where particularly NPH is a cheaper in terms of cost of insulin, you can also use NPH as your basal insulin. For those where if you started with NPH and you're not at target, then you can consider twice daily NPH regimens, where whatever your NPH dose that you had used initially as your basal dose, take 80% of that, give 2/3 of that in the morning and 1/3 in the evening as the twice daily. If you're not achieving goal, then you can consider the self-mix split insulin regimen, where you give 80% of the total dose with 2/3 before breakfast and 1/3 before dinner, but add 4 units of shorter rapid acting insulin to each injection, or 10% of the reduced dose of NPH. So this is where you would mix them in a syringe with the rapid or short acting insulin along with the NPH, where you would give 2/3 of that in the morning, 1/3 of the dose in the evening. Then you can use your pre-mixed insulins, the ones that are already mixed, like our 70-30s, our 50-50s, 75-25. Again, starting with 2/3 before breakfast and 1/3 before dinner, and adjust based on individual needs. These insulin regimens, you may have more hypoglycemia, or it may be a little bit more difficult to control because individuals will need to eat on a regular basis with consistent carbohydrates. And sometimes that's a challenge when you use this particular regimen, these fixed regimens. I personally like the weight-based insulin and correction algorithms, where I will calculate in terms of starting with 0.5 units per kilo per day for my total daily dose. I give half my dose as basal. And then I look at the insulin to carb ratio, and I use the rule of 500 to calculate my insulin carb ratio. And then I like to calculate my insulin sensitivity, because that is what I use for my correction algorithm to reach a target correction of 100 milligrams per deciliter before meals. And to give an example of that, if I had an individual that weighed 100 kilograms and I started with 0.5 units per kilo, that would be 50 units. Half of that would be my basal insulin, which would be 25 units. I would then take my insulin to carb ratio of 50 into 500, and that equals 10. So they would need 1 unit for every 10 grams of carbs that they eat. And then my sensitivity factor would be 50 into 1800, which gives me 36. So I would take my current blood glucose minus my target blood glucose divided by my insulin sensitivity factor. Then that would give me 2.7 units to be added to my insulin to carb ratio if they're out of target range. I tend to use a lower one if I'm between 2 and 3, so I might start with 2 units added to that. So this is a useful way, particularly for those who are able to carb count and also use the math to use this. So this is something that is very useful in terms of getting your patients into control. This is somewhat what we use for pump therapy. I'll talk about some of the connected pen insulins that can be used for patients who want tighter control of their diabetes. The connected pen device pretty much uses this principle where you will then put in the carb ratio, you put in the sensitivity factor, and it also takes into account active insulin on board. So this will allow patients from over insulinizing themselves if they do multiple boluses because of the residual insulin that is there, and then you don't result in late evening hypoglycemia. And these are very useful for those, and they can see it on their phone. They put in their numbers and it tells them how much insulin to give. Usually we have to put a prescription, and this happens to be a prescription where we send this off, and then we put in their carb counting, their insulin carb ratio, their sensitivity factors is programmed into their pens, and they use this. So this is a useful tool for those who want tight control and using the insulin to carb and correction algorithms. Insulin pumps and glucose sensors are often used for those who want tight glucose control, and they use a lot of that in terms of carb ratio and insulin sensitivity factor. And I believe you've had talks on this, and I won't go into a lot of detail. But the continuous glucose monitors, I think, are really helpful in terms of educating patients in terms of, what are they eating? How is it affecting? I've seen tremendous changes in patient behavior when they use these continuous glucose monitors. Blood sugars were in the 300s, but then over several weeks, you find that the blood sugars are now into the 100s because they're getting immediate feedback for those that have the personal real-time continuous glucose monitors, that they continuously see what their blood sugars are and what is driving their elevated glucose. We have the intermittently scan continuous glucose monitors, where if they scan the device on their arm, they can then see what their blood glucose is at the time. And as long as they scan every 8 hours, They can see their profile in terms of what their glucose trend has been. And then we have the professional CGMs where they come into the office, the nurse or the medical assistant puts the device on, they wear it for a week or two, they keep a log or a diary, they bring that back, and we make adjustments in their insulin therapy based on this. So these are very useful tools in terms of improving glucose control. Then these have standard glucose reports. When they are using continuous glucose monitoring, we'd like for most of their glucose levels to be greater than 70%, using in terms of time in range, anywhere from 70 to 180, reducing our hypoglycemia to less than 5%, and our hyperglycemia to less than 25, 30%. This is very useful when we upload this data, or for those where we can do remote patient monitoring and actually see the data in real time. Digital health tools are very helpful too in terms of having patients to use these in terms of apps and logbooks and fitness trackers and so forth. So I tend to encourage patients to use these tools to help them to manage their diabetes. We do have to be concerned about medication costs because they're extremely expensive. Many of the treatments, even though we talk about them, but if someone is on a fixed budget or they're on a formulary where their insurance is not covering certain agents, but you want to use them, we have to be mindful of this. And oral medications, as you can see, the ones, sulfonylureas, the TZDs, the metformins, are relatively inexpensive, and generally most patients can afford those. But when you have to start adding more agents to their treatment regimen, as you can see, your SGLT2 inhibitors are increased in price, your GLP-1 receptor agonists are even more expensive, and we don't use a lot in terms of these other agents like bromocriptine and pramlintide. So these are more expensive agents, and this is a 30-day supply if they were to buy these agents without any kind of cost sharing or coupons, or they just had to pay out of pocket if they don't have insurance. Regular insulin is relatively cheaper, as well as NPH. The premix vials and pens are cheaper, rapid acting. And then as you start going up in terms of the U500 concentrated insulins, our long-acting insulins, our GLP-1 long-acting insulin combination, and our inhaled insulins are extremely expensive. And if they have to pay out of pocket, they probably will not be able to afford them. So we have to be creative in terms of how do we manage patients who are not well insured, who may have to pay out of pocket, or they have a high copay. We have to think about these things. Now, one of the things that I looked at, because I do treat a predominantly Medicaid and an indigent population that happens to be uninsured, and when they come into the hospital and they're newly diagnosed with diabetes, they don't have insurance, I've looked at Walmart formulary, and I added up what we could do and send them home that possibly could be reasonable. And as you can see, the Walmart brands of NPH and regular and their 70/30 vials are relatively inexpensive, $25. And their syringes, you can get 100 for $4.99. Their Rely On meter is $9. Their Rely On test strips, $107.88. Lances, $162. So the total for the vials and the supplies came to $73.49. If you wanted to use the rapid acting insulin, they do have a Rely On Novolog, a little more expensive. The vial and the pen is even more expensive, but again, it is not as expensive as some of the other commercial brands of insulin. Even the ones that are the biosimilar or the logic add-ons that are available, they tend to run about $100, $125. So they still are relatively expensive for those that are on a limited income. Making sense of patient assistance programs. So a lot of times we do have to have our patients use these resources. And so patient assistance programs eligibility, some of the pharmaceutical companies will have this available where patients can get their medicines cheaper. But there are stipulations like no private insurance, no Medicaid. They have to have proof of income, although they've loosened the area. Some of them 140% above the poverty level, you can still get these medications. Care only who receives Part D benefits may qualify for low income subsidy. These dual eligible individuals where they can get the Medicaid as well as the Medicare to help with their diabetes medications. The private insurance, the copay assistance cards, I use those quite a bit because even with my patients, when I put them on these insulins, they still say I have to pay $150 when I go there, my copay, and then all the other medications that they're on, that I tend to get them to either go online and get their copay card, or sometimes they will bring us the copay cards to our office. And so they will get a copay card. So if they go online, they can print that copay card. They have to register, and then they present it to the pharmacy, and then the pharmacy runs it through. And then generally they can get the medications for sometimes as little as $10 or $25 for a 30 or 90-day supply of insulins or other medications. So this is very helpful for patients that have insurance where either they have high deductibles, they need copay assistance. This is useful for getting the patients some relief in terms of paying for their medications. I have here in terms of patient assistance programs by manufacturer. AstraZeneca has some, Barrington has them, Lilly Cares, Merck, NovoCare, Sanofi, Patients Connection Assistance. So these are sites that you can send your patients to. And when you go on these sites, they tell you what medications that they can get at a reduced rate. And then they have to fill out the paperwork, whether they need to show income, proof of income, or their copay cards. I wasn't sure because I'm on the East Coast, what is the Medicaid for the state of Washington. I looked online and I may not be correct, but I don't know if it is Apple Health, but we have to be cognizant of our Medicaid patients, the PDLs, the pharmacy drug listings that are available. And I constantly have to look that up when I'm prescribing medications to, because if it is not on the formulary, they will not get the medication. We usually keep a chart. We have it on all of our desktop computers in terms of what is covered in terms of the insulins, whether it is glargine or the biosimilar glargine, which a lot of them have moved to, and some of the add-on bioactive insulins and so forth, that we use that to make sure that we are giving them the medications that will be covered, and when they go to the pharmacy, they will get them. Because if you prescribe the wrong one and they're told they have to pay $400, they will generally walk out and not get their medications. So being aware of that, looking at it, knowing what's on the formulary, and then sometimes certain medications are needed or you really want your patient to have, then we have to do a prior authorization. And many of these Medicaid formularies generally want you to do step therapy. So after you have tried metformin and they haven't responded, or they're intolerant of it, and you wanted to add a GLP-1 receptor agonist, then you would have to show that your patient did not do well on the metformin, or you wanted to add an SGLT2. So a lot of them will require what we call step therapy. So being aware of that is also helpful in terms of making sure your patients get the best treatment possible. And another tool that I use is apps. Download them on my phone. This particularly comes in handy for the commercial insurance because there's so many plans out here. Different states have different plans and coverage. And when I'm prescribing certain medications, insulin, I have to know whether glargine versus detamir or glutag, whichever one is going to be the lowest tier for that particular patient. So these are apps that are available that you can download on your phone, and you can get an idea of what may be covered so your patients can get the medications that would be a benefit. And low cost to them. And I believe this is the end. Anyone have any questions? This concludes my talk.
Thank you so much, Dr. Nunlee-Bland. Really helpful. My background, I think I mentioned, as a family physician, and now obesity, I have often felt more comfortable, which is strange, with phentermine versus insulin. So I appreciate all the tools that you gave us today.
My name is Dr. Pratamathaya. I am one of the family physicians at CMAR, south of Seattle in the Des Moines area. My clinic population is very similar to the rest of all of our clinic populations, mostly Medicaid or uninsured, some Medicare. And so I will be presenting one of my patients. She is 66 years old, and I am new to CMAR, and so she was transferred to me from an outside clinic in December. That was the first time I saw her, December 2021. When I saw her, she had not been taking any of her medications for a couple of months and wanted to get back in with a physician and get her health under control. She was first diagnosed with diabetes in 2016, had some symptoms of polydipsia and fatigue, and had a random glucose of 405. And she didn't return for several months, and then came back in for a recheck. And at that time, her A1C was 6.6. From what I can see from the outside records, she was then started on metformin, an ACE inhibitor, and a statin. And then she was kind of lost to care for about a year. Unclear how long she was taking meds at that time. She then presented to another clinic. I don't have any information about what her labs looked like at that time, but from other information in the chart, I'm able to gather that she was started on insulin at that time. That would have been in 2018, 2019. The next available set of information that I have is actually from 2020, when she was admitted with DKA with a glucose of 600, a beta hydroxybutyrate of 5.4. And at that time, she was again restarted on all of her meds. According to all of the notes from that emergency room and critical care encounter, she had been taking insulin, not sure what doses, but was taking it kind of PRN when she felt funny, when she didn't feel well, and was not taking her statin, was not taking her blood pressure medicines either. After that encounter, she was then plugged in with another care organization in the area and was on track for a little while. At that time, she was on long-acting insulin, losartan, a statin, and metformin. Throughout that time, her A1Cs remained above 10 to 12. And when I saw her in December of 2021, her A1C was 10.5. At that time, she was taking the medications that are listed here, the insulins that were listed here. She was not taking any blood pressure medications, and she was not yet taking the GLP-1 receptor agonist. Again, her insulin use was pretty sporadic and erratic. So I chose to focus on getting her more comfortable with taking her insulin and really seeing what that would do for her glucose control. I saw her a few times between December and February, and each time I saw her, she was very reluctant to check her glucose. She would check it every few times a week, always fasting, wasn't really checking it, even though she was taking prandial insulin. I had given her logs. We had talked about getting a continuous glucose monitor, and she was very reluctant. She didn't want to have something in her body. So this is something that's been an ongoing struggle with her. The other labs that I have for you are the update to the case. She did drop in her A1C when I checked in February down to 8.5. And then I saw her again in May, and she had climbed back up to 9.0. Throughout all of this, it's been a very frustrating experience for me as a newer provider, navigating her not wanting to take all of her medications. She will choose to take one insulin for a couple of days and then choose to take another. She won't take her. She stopped taking the statin that was prescribed for her by an outside care physician and has refused to restart it with me due to concerns of it giving her headaches. So in May, when I saw her, I talked to her about the importance of what we need to do and what the pathophysiology is and why it's important to get her glucose under control. She was agreeable to starting a GLP receptor agonist. That was in May. I saw her again 2 or 3 weeks later, and she had not yet started the GLP-1 receptor agonist. So I don't have any updates based on that change in her pharmacologic plan. So that's where I stand with her. I'm sorry if that was a little bit all over the place, but so is she. And so am I when I'm with her. So any kind of guidance or anything that we can glean from her case, I think would be really helpful.
Thank you, Dr. Muthaiya. Yes, this is diabetes, right? So, it's often very tough. I got the story. It was all over the place because that's how the patients are often. So it's really not a negative at all. Okay, so we don't need to go over all this, but to very briefly summarize, we have someone who is 66. Actually, before I move on, can we ask a few questions? What is her ethnic background?
She is African.
Okay, are there other questions of the panelists? I actually have a slide of all the questions that I collected. Maybe I'll get to that. From what we heard from Dr. Muthaiya is we have the 66-year-old woman. She's of African descent, diagnosed about 6 years ago with maybe one random blood glucose in the 400s. I don't think you had an A1C at the time, but she was started on metformin somewhere along the way, lost a follow-up, showed back up maybe a year or two later, and then needed insulin. Then a year later, had severe hyperglycemia and landed up with DKA with positive beta hydroxybutyrate. I think that's what I heard. Then, of course, the story is very bouncy because there hasn't been continuity of follow-up for patient-related reasons or otherwise. As of today, after having established with Dr. Muthaiya, she's actually been coming to clinic, which is a big positive. And her current regimen includes basal bolus insulin. So she's on glargine and she's on Lispro. Hopefully she takes it before her meals. Then she was recently started on a GLP-1, which she hasn't initiated. And she also has hypertension and hyperlipidemia and has been hesitant to take her statins. From other things I gleaned from the case history, she's of Medicare age. She's widowed. She has a grandkid who she takes care of. I think you shared that in one of your emails. And she has a BMI of 30, and her most recent labs show an A1C of 9%. And you can see her lipids there. She has an LDL of 163. If there's any other questions others have. I think I had a question on duration of diabetes. You answered that during your presentation. So about 6 years of diabetes. Then we got some of the story on her diabetes management. She's been very intermittent in her care until recently. A1Cs have ranged between 10 to 12% is what I heard. And then medication adherence has been very big barrier. That's what it sounds like. I think Allison had questions on eating patterns. Did you want to share a little bit about her eating patterns? What did you glean from what you were able to find from previously?
Yeah, so she tries to eat a breakfast, lunch, and a dinner. She doesn't really snack throughout the day. And for breakfast, she'll have peanut butter and jelly on wheat bread with a coffee and some sugar, or she might have some honey bunches of oats cereal. She might have a sweetened yogurt, and sometimes she'll have an egg as part of her breakfast. For lunch, she tries to have some grains, usually quinoa, and will have some chicken or fish for protein. And for dinner, she has a salad with some chicken that she says is usually baked, and then a fruit.
Do others have any questions of Dr. Muthaiya? Laura, Gail, Allison?
Yeah, looks like Gail has her hand up there.
Yeah.
I have a question. In terms of having difficulty affording her medications, she's Medicare, and sometimes they get into the donut holes and then they can't afford it and then they're not compliant. So I was wondering if this has been explored.
Yeah, and that's been something that I've talked to her about. She's able to afford her insulin. When she was previously on Jardiance, she stated that she didn't tolerate it, but she wasn't really able to give me an answer. And when I asked her if it was related to the cost, she said that was part of the problem, in addition to her having stomach issues. She said it flared up her arthritis. So I think the financials had a effect on her affording Jardiance and her compliance with that medication. For her GLP-1 receptor agonist, we were able to use the patient assistance program to help her with that. And so that was one of the reasons why she was agreeable to taking it. I do think that has a role in her ability to adhere to the medication regimens that we have discussed.
Also, I have a question. Are you able to put a professional CGM? I know she said she didn't want one, but just to show her what the pattern may be over a week or two, because sometimes just educating them on that.
We hadn't talked about the professional CGM. We had just talked about a freestyle or something that she could have and monitor herself. After your presentation also, I really think that's something that could benefit her a lot, especially because when we do go over her labs together, she does seem highly motivated, and then she'll do well for a few weeks and then she tapers off again. And so I think that having that feedback for her, she's an extremely smart lady, I think that would really help her. And so that's something that I'm going to definitely pursue a little more incessantly after this presentation.
What are her beliefs around insulin? So you said there were times when she would take her insulin and then stop and then go back on there. What is her psychosocial history? She's widowed and she's got a grandkid, it sounds like, but there's always some story behind that we haven't peeled the layer of the onion, right? So especially with people with diabetes, have you gotten a sense of anything?
In terms of her beliefs around insulin, she really worries about a lot of side effects and worries about a lot of aches and pains that she has. She will be very quick to say it's the insulin that's doing this. She is very anxious about all of her medications. For example, the GLP-1 receptor agonist, when I had prescribed it, she was very excited to start it. And then when I saw her 2 or 3 weeks later, she hadn't started it yet because she had received an email about a recall on an insulin. She assumed that meant that all injectables were recalled and dangerous. And so she just has a lot of anxiety about medications in general. And insulin is just one of those medications. Her psychosocial background, she seems to have really good support, but she also seems to be the caregiver for a lot of people. So I specifically mentioned her grandson when I was emailing with you all because she's missed a couple of appointments because her daughter was working, and she is her grandson's primary caregiver when her daughter is working. I also had an instance where he threw away her medications or dumped out her medications into the sink at one point. So I think that is a stressor for her, both physically and medically, in terms of being able to access her meds.
I have a quick question. You mentioned she's checked a couple of blood sugars, maybe a few times per week. Do you remember what some of those recent readings were?
Yes, at her last visit, beginning of June, I have them written here. Her fasting glucoses were 135, 146, and 128.
Okay, those aren't too bad at all. And yeah.
But they're not always consistent with what her A1C is too. And that's one of the questions, one of the things I'm a little concerned about or would like your feedback.
Okay.
And this is just Allison. I was just going to chime in. It sounds for this patient that's been in and out of care that she's really connected with you. It sounds like she's seen you. So yay, building on those successes. In our primary care network, we have dietitians and care management nurses and diabetes educators that are embedded in our clinics. And my understanding of CMAR is you have registered dietitians and then also a nutrition grad that teaches general classes. So with how this patient responds to your reach outs and your nurse or dietitian in between your visits to keep patients like this engaged, because I know in our situation, and then I'll just stop talking, some of our providers are booking out 2 and 3 months, and as much as you wish you could see that patient back, sometimes it's not. But in that medical home at CMAR, do you guys have the ability to leverage allied staff? Was my question.
We do. The issue has been in our clinic, I'm sure lots of clinics actually, the issue has been staffing. Our diabetes educator that we have on staff to help with education on chronic illnesses, we've been sharing with 2 other clinics for the last 6 months or so. And so that's placed a burden on it. And the dietitian aspect, she actually declined seeing a dietitian the last few times I talked to her. This last time I saw her, she did agree. And so she has an appointment pending with our in-house dietitian in a couple of weeks.
I'll just throw in one last comment. Sometimes people don't want to see dietitians because they have this feeling that you're going to take away everything that you love to eat. And so sometimes saying, I don't have time to see you in 2 weeks, but can you meet with my dietitian who also provides diabetes education, sometimes minimizing what they think is going to happen. Or I don't know if your staff is trained that way to help you checking in with glucose data, sometimes can be helpful. Or I forgot to mention, even ask if you have pharmacists like CELU embedded in your clinics.
Yeah, thank you, Allison. So that's an important point, which I will point out under general goals shown here. So the importance of trust building and involving your ancillary staff like pharmacists, dietitians, nurses, for those frequent touches and establish that rapport. Sounds like she trusts you and she's been coming back. So that's a big win, like Allison mentioned. So I just want to emphasize that in diabetes, it's all about trust building. There may be times when you don't do anything, you just have a chat and they leave the clinic with a smile on their face. You've done their job without actually adjusting any medication. So I just want to point that out. Dr. Mutaya had 3 specific questions when she initially submitted this case. And I think those are very important in this patient. We might not get to the statin part, we'll see. I think this diagnostic dilemma is going to be very important because you mentioned, and I'm gonna ask you to do something, Dr. Mutaya, when I'm talking about this. If you are able to find a urinalysis from several years ago and see if there were any ketones in her urine at any given point, especially early on during her diagnosis. The first question you asked was, what type of diabetes does this person have? And your question was, is this type 1 or type 2, or is this type 1.5 diabetes? And I added, could this be LADA or is this atypical diabetes? So we'll walk through this with what we have. So I wanted to show you how the ADA categorizes diabetes in 2022. So there's type 2 diabetes, which we're all familiar with. There's type 1 diabetes, which is absolute insulin deficiency or autoimmune diabetes, where the pancreatic beta cell is destroyed. So these individuals need insulin, as Dr. Nunlee-Bland pointed out during her insulin talk. Then there's a version of type 1 diabetes, which I have put under type 1 diabetes, which is what you may be familiar with as LADA, latent autoimmune diabetes of adulthood. These days, the ADA puts it under the umbrella of type 1 diabetes because LADA is just my gentle autoimmunity, which starts in adulthood and floats for many years. It is autoimmune diabetes. So you can use the term LADA and you can use it for diagnosis and coding, but it's essentially autoimmune diabetes. There's monogenic diabetes or atypical diabetes, but the clue for that is these are rare conditions because of gene defects in insulin processing. It's a diabetes that occurs in early adulthood or in adolescence, age under 35. If you're trying to scratch your head and figure out, does this person have some kind of atypical diabetes? There's actually a MODI calculator, the website I've given up there. You can go in there and plug the patient's age. It won't let you even calculate it if the person's under 35. So if you put even 40. So this individual probably doesn't have atypical diabetes or MODI. Secondary diabetes is due to other causes like pancreatitis, drugs, etc. Then you had a question, is this 1.5 diabetes? Or some people also bring up a type 3 diabetes. These are not actually classifications you want to use because there is no such thing as type 1.5 or type 3 diabetes. It's either type 1 diabetes or type 2 diabetes, which requires insulin due to progression. So I just wanted to point that out. This is important because it was a question in your mind, what kind of diabetes does this individual that you're treating have? The initial presentation may not be clear. You may inherit them like Dr. Mutaya did 5 years later, and then you're scratching your head like, why is this not fitting? So clues towards diagnosis will become apparent if you see that you put them on metformin, you think this is type 2 diabetes, and there's no response to oral agents within 3 months. and they say to you, I am taking my medications regularly, or they progress rapidly to insulin therapy, that should give you a clue that this is not your bread and butter type 2 diabetes. If it's type 1 diabetes, DKA, especially in adults, DKA may not be a presenting feature. It's not a dramatic presentation as an individual gets older. And I want to point out here, type 1 diabetes can occur at any decade of life. 20s, 30s, 40s, 50s, all the way up to age 90, you can have type 1 diabetes. You're probably thinking, okay, I don't know why this is even important. This is important for treatment. So we're trying to figure out what this particular individual has. Could this be type 1 diabetes? Because she presented with ketosis, ketonemia, with positive beta hydroxybutyrate and a glucose of 600. The diagnosis was DKA. Is this type 1 diabetes? Because then the whole discussion you have with your patient is going to be completely different, and you wouldn't go to specifically SGLT2 inhibitors. So it's important to know. I bring up LADA here again is because adults may sometimes float with suboptimal A1C in the pre-diabetes range for years and years. They get put on metformin, they will do fine. Then all of a sudden, they may need sudden progression to insulin. And these are people who may be lean, have lower body mass index. And I want to point out, even people who have type 1 diabetes who we think are lean in general, these days the average BMI is about 30, 29 to 30 if you look at the type 1 cohort. So if there's a question in your mind that this person doesn't fit the typical type 2 diabetes, start thinking outside the box. So if this is autoimmune diabetes, they may have antibodies towards the islet cells, something like GAD65 antibodies. The misdiagnosis is common. What clues do you have from the chart in front of you from the patient? So go back and look and see when the diagnosis was. Was there rapid onset of polyuria, polydipsia? Was there catabolic state, rapid unintentional weight loss? Does this person have autoimmunity in the family, in themselves? Do they have hypothyroidism? We didn't hear anything about that in this patient. This individual has a BMI of 30, BMI of less than 25, definitely lean individuals. Start thinking, okay, this is not your typical type 2 diabetes. And then I asked Dr. Mutaya to see if there was any urinalysis, because ketonuria can be found in adults, and especially before you start treatment. And if you see that, especially in someone who's hyperglycemic, start thinking, okay, this may be type 1 diabetes. Yes, we're not thinking, there are situations in people who have type 2 diabetes who may have ketones and ketonuria and may present with ketoacidosis, especially if they're very severely hyperglycemic or have an infection. In a leaner individual who has hyperglycemia, they're not responding to oral medications, it could be type 1 diabetes. You can look at the BMP and see if they have a mild anion gap. That's another clue. So these are all things you can actually just from the chart glean information from and see what's going on. So since you asked the question, could this be type 1.5? And we've decided that there's no 1.5, it's either type 1 or type 2. If you are thinking this person has insulin deficiency, maybe adult onset autoimmune diabetes, that is type 1 diabetes, it will be useful to get antibodies. GAD65 is the most common. 65 to 70% of individuals who have autoimmunity may have GAD65 antibodies, glutamic acid decarboxylase antibodies. Others are IA2 and zinc transporters. GAD65 is very easily available. All of these can be ordered in Epic. Zinc transporter, it's a send out to Mayo. IA2 also, I'm guessing you'll have to send it out from your clinic. I wouldn't check insulin levels, so they don't help, but C-peptide, early in the diagnosis, difficult to use and interpret. And someone with established diabetes, like this person, you can check to see if they have any detectable. C-peptide is that C part of insulin. When the C part is cleaved away, that's when insulin becomes active, and that C-peptide tells you that the person's beta cells are actually secreting insulin. So if this individual has a C-peptide that's low, then you know there is insulin deficiency. This could be autoimmune diabetes if they have also positive antibodies. Something to keep in mind. I'll stop at this juncture and see if any of our panelists have any thoughts or counter thoughts to this clinical presentation for this patient.
I agree that I think checking for autoimmune antibodies, because I learned that I can't look at an individual now and tell if they're type 1 or type 2. Just to give an example, we just had a 56-year-old that was admitted in DKA. BMI was close to 40, and her autoantibodies were positive. And so we pretty much know that probably she's not going to do well on the oral agents or may not do well on GLP-1 agonists. So testing for autoantibodies, I think, would be very important in this individual. Also, since she's had diabetes for a long time, I agree maybe a C-peptide might give you an idea if she's insulopenic, then you're probably going to have to work with her for insulin. If not, then maybe other agents may be helpful.
Yeah, I agree. Thank you, Gail. Yeah. So I think I don't know if you found a UA or not.
I did.
Okay.
I can see two of them. One was at time of diagnosis in 2016. It was negative for ketones.
Okay.
And then on her admission with DKA, she was positive for ketones.
Wait, was it 3+ ketones?
3+.
Yeah. Okay. So she was ketone. So she was insulin deficient. So she could be type 1 diabetes. She could be type 2 diabetes, ketosis prone type 2, but I don't know, something about her smells like type 1. So I agree with Dr. Nunlee-Bland. If she still comes back to you, she should have antibodies checked. It's going to be very important for diagnosis because so your whole treatment is going to change. If this is type 1 diabetes, you are not going to go to the SGLT2s you've tried and she didn't do well on them. It's a life-changing diagnosis for adults. This means insulin dependency. They have to take their insulin. It's a lot of learning. They have to change their mindset. So it's education. This is where I bring in folks like Allison. And if this is type 1 diabetes, you might want to think about sending them on to specialty care. So that's it, because then, as somebody mentioned, or maybe it was just you, CGM use is going to be very important. You go down a completely different path. I think diagnosis itself is something you need to establish here. I'll skip over social determinants of health, but one of the other questions you had asked, this may not be relevant at this point, but you had a question on how do I adjust other medications when I start a GLP-1? And I'll bring this up because I have the slide. If you're starting a GLP-1 agonist in anybody, you don't need to adjust metformin and SGLT2 inhibitor. If you have somebody on any of the gliptins, the DPP4 inhibitors, sitagliptin, allogliptin, etc., that would be duplicative therapy because it acts a similar way as a GLP-1, so you'd have to stop them. And you might need to adjust insulin dosing, the sulfonylurea, etc., depending on how effective the GLP-1 is. If it's suppressing their appetite and they're not eating as much, and if they're on mealtime insulin, you definitely need to decrease as well as the sulfonylurea. Again, there's no real guidelines on how this is. It's more an art than a science. But if they are checking, then or if they have a intermittent scan CGM, it's easier to do. You can teach the patient, but many times if the A1C is high, like 9% in your patient, and if they have type 2 diabetes and I'm starting them on a GLP-1, I don't really adjust the basal insulin. You don't really need to. I'm going to skip the coverage because Dr. Nunlee-Bland had wonderful slides on that. For goals, I think Silu asked about blood glucoses, and you had said that her blood glucoses are 150 to 160 or maybe 130. So that if her A1C is 9% and you have an average blood SMBG of 120, 130. So there's a discrepancy. Fasting is acceptable. What I think of is, does she have higher blood sugars during the day that we're not picking up? Or she's of African descent. People who are of African descent can have something called overglycosylation, meaning the A1C can be inappropriately high, but they can have normal or acceptable blood glucoses. So you have to make sure you are assessing for that. And the way you do that, you can check a fructosamine, which gives you an average blood glucose for the last 2 to 3 weeks. And you can Google acetylfructosamine comparison, and it'll tell you if fructosamine of X, what is the equivalent Y. That would be something to do. I'm going to open up to the panel for other thoughts and suggestions. I'm going to ask Silu if she has somebody like this, what would she do if she's seeing a patient? So we can hear from Silu, but I don't know that we can give you any specific treatment goals, but I think there's more diagnosis and other things that you can work on in the short term is what I'm going to say, but I'll stop talking and I'll ask the others to chime in. Silu, did you have any thoughts?
Sure. The next steps are really to have the patient collect a couple more postprandial blood glucose readings for you. In my practice, I see similar patients to you. Many times their fasting sugars do look good, but their A1C is 9 or 10. And I create that discrepancy for them and say, your fasting blood sugars are 120 to 130, but based on your A1C, the average of your sugars is 210 or higher. Where are those higher sugars coming in? And I'll draw them the graph of how sometimes in the morning your sugars are good, but later in the day your sugars might be high, and we don't know unless they check some for us. I even start them maybe a couple times a week, 2 hours after their biggest meal, or even at bedtime, just to see what those are like. The other part I wanted to emphasize was, since you mentioned she didn't start her Tide extended release yet, is if she's received education on how to use that injection device.
Yes, our pharmacist at the clinic had shown her how to use it.
Okay, fantastic, because Hydurion B-Size is one of our more complex injection devices. It's not intuitive to use, it's a suspension, and there's risk for injection errors with that. One thing to highlight about Hydurion as well is it does have a pretty long onset of action. Most of our once weekly GLP-1s, you might see the full effect over about 4 weeks. With this agent, it can take up to 8 or 9 weeks to see the full effect. So she might still be seeing blood glucoses trend down to that point. If she does start and if her fasting readings are good, like Dr. Subramanian mentioned, you could consider an empiric reduction in maybe her insulin glargine, given that we know some of those sugars actually look pretty good, just to prevent morning hypoglycemia. And then thinking about whether or not the prandial insulin needs to be adjusted if she can collect some more postprandial sugars for you.
Thank you.
So a few thoughts, yeah.
I was
Allison,
just
did you have
gonna
something? Yeah, go for
just
it.
quickly say that sometimes with Silu's approach of using, if she's willing to do those paired check where she checks before and then maybe 2 or 3 hours afterwards, and what she might see is that there's some meals that make those glucoses go up higher than other meals. I know Dr. Nunlee-Bland talked about an insulin to carb ratio, and sometimes we have used just a simple thing like a small, medium, and large meal approach to mealtime insulin dosing, where if 14 is the go-to dose, if she's eating a smaller meal, and once again, the concept is, what is the carbohydrate component of the meal? Sometimes I think patients think I'm eating my biggest meal and it might be a giant salad with chicken in it, but it's the carbohydrate component of the meal that we titrate the insulin to. So just sometimes by just discovering what are some of the common dinners that she might eat, using that. If it's small, it's 10. If it's medium, it's 12 or 14 or something. That can be really helpful. Or if she's eating with her grandchildren and she's having a little extra carbs because it's a birthday or they're having pizza, maybe that's a 16-unit meal. So just giving her that kind of approach, seeing if you can get her to the dietitian to help her with assessing what are some common things and not making her feel bad if some of the glucoses are high, but we just need more information in order to individualize it. I always tell patients that we don't have a book that we can look in and just say with a statin, take 40, take 80. With insulin dosing, it's so individualized. So sometimes, to Silu's point, we just need a little more data.
These slides will be available for people to look at, but statin hesitancy that you're encountered with this patient is very common, as you probably already know. Misconceptions are very common. People worry about side effects. They don't want to take another medication. They want to try diet and exercise before they start a statin. It's all perceived. And some of the common things that people worry about is, will it damage my liver, the memory issues? These are all things they hear about. So this is all very common. And what do you do then? Many people are open to trying it, but it's again a conversation. It's like everything else, you gotta try again. It takes time, as with anything. If this woman has diabetes, you're working on getting her diabetes better managed. And then eventually, once you've crossed that hill and you are going to talk about her other stuff, which includes her statin and use of a statin, if you cannot convince her, you might offer her a coronary artery calcium test, which if there's calcium deposition in the arteries, I mean, again, I don't want to take up too much of your time, but it's an option. However, Medicare will not pay for it. So it's a cost. Anywhere from $99 to $200. If there's a positive CAC score and it's intermediate to high, that means they need to be on a statin. So it gives them that incentive, oh, okay, I need to be on a medication. So it's just one of those things you just have to keep trying. And it's very common. Statin hesitancy is quite common, but again, it's a discussion, ongoing discussion. And I'll leave it at that.
Thank you so much for a great session 7. Savita, I really appreciate you going through the case discussion. Thank you so much to all our panelists and Dr. Mathai Mathiah for presenting the case, also to our lecturer today, Dr. Gail Nunlee-Bland. Thanks so much for attending and have a great rest of your week.